My name is Stine Morbjerg. I am working as a postdoc at the Danish Headache Center. In this presentation, I will lay out the diagnostic criteria and subclassification in trigeminal neuralgia. But first, I would like to present a case of a 49-year-old woman who was referred from her GP because of intense pain located around the upper left cheek. Her pain felt like electric jolts of lightning, and it lasted only a split second. The pain was triggered by light touch and cold wind to the left nostril and cheek. At the first visit here, the history was further explored, and we learned that the pain onset was 3 years ago, and it was memorable to the patient as the pain was so intense. The pain onset had not been preceded by trauma such as a tooth extraction, and there was no history of a facial zoster rash. The patient had had several dentist checkups, but there was nothing abnormal about the teeth. The patient had never experienced the ipsilateral autonomic symptoms such as a lacrimation or a runny nose in association to the pain. The patient only experienced one type of pain, and that was this short-lasting, intense and paroxysmal pain. The patient was diagnosed with trigeminal neuralgia as she fulfilled the diagnostic criteria based on the history. Here are the diagnostic criteria in trigeminal neuralgia. Trigeminal neuralgia is defined by recurrent paroxysms of unilateral pain in one or more distributions of the trigeminal nerve, with no radiation beyond the trigeminal distribution. The pain is short-lasting, lasts from a second up to 2 minutes. It is severe in intensity. The pain quality must be electric shock-like shooting, stabbing, or sharp. The pain is precipitated by innocuous stimuli within the affected trigeminal distribution. And finally, the pain is not better accounted for by another ICHG3 diagnosis. That could be other causes, such as the pain is a consequence of a herpes zoster rash, that it is a post-traumatic neuropathy or a trigeminal autonomic headache, such as SUNC and SUNA. It could also be an odontogenic cause, such as a cracked tooth. That is not included in the ICHG3. An important change in the ICHG3 is that there must be trigger factors in order to set the diagnosis of trigeminal neuralgia. So as a part of a detailed history focusing on exploring each item of the diagnostic criteria, it is important to be familiar with the most common trigger factors and trigger areas. Most patients have several trigger factors, and the most common triggers are light touch, talking, chewing, toothbrushing, and washing the face. Here, I'll show you a picture of the most typical trigger areas in trigeminal neuralgia. As you can see, there are several both intra and extraoral trigger areas, the most common areas being the nasolabial area, the upper and lower lip, the chin, the cheek, and the alveolar gingiva. For subclassification, the patient from our case was then referred to an MRI to visualize a potential neurovascular contact between the trigeminal nerve and a blood vessel, and to rule out secondary causes of pain. Here is the structure of the subclassification of trigeminal neuralgia. It is subclassified into either classical trigeminal neuralgia, where there is a neurovascular contact on the symptomatic side with morphological changes of the trigeminal nerve, or idiopathic trigeminal neuralgia, where there is either no neurovascular contact or a neurovascular contact without morphological changes of the nerve. Another important subgroup is secondary trigeminal neuralgia, where the disorder is caused by multiple sclerosis, a tumor in the prepontine angle, or other causes such as a brainstem stroke or an ectatic basilar artery. Finally, classical and idiopathic trigeminal neuralgia is divided into purely paroxysmal pain and with concomitant persistent pain. The next presentation on trigeminal neuralgia by Dr. Truini from Rome will go over the underlying pathophysiology in trigeminal neuralgia and explain the medical and surgical treatment strategies. Thank you for watching.